It's 9:45 Pacific time, so we'll get started. Good morning, everyone. I'm Marian Newhouser, one of the co-chairs of Prevention and Epidemiology, and I'm joined by Banu Arun, the other co-chair of Prevention and Epidemiology. We are really delighted to both welcome you to Seattle and have you in this in-person hybrid event today. We have over 27 people join us virtually, and other people are trickling in. We have a mix of in-person and virtual presentations today. For people who are presenting in person, we will invite you to come up and speak from the podium. We have a slide advancer for you. For those of you who are presenting virtually, we will introduce you, and then please just call out next slide, please, when you want us to advance your slides. People who are virtual, please put questions in the chat, and after each presentation, we'll have some time for questions, and we'll go back and forth between letting people ask their questions from the chat. And then if you're in the room and want to ask a question, please come to the microphone and speak into the microphone so that the people who were on the Zoom can hear appropriately. So with that, I think that we will get started, and I will turn it over to my co-chair, Dr. Arun, who will introduce our guest speaker for today.
Thank you so much. And I also would like to welcome everyone in person, as well as the ones who logged in, and we have close to 40 people now. So that's great. I have the pleasure to introduce our speaker for this session, Dr. Karen Hastings. She will be talking about biomarker development for early phase clinical trials for melanoma prevention, a topic that is becoming very interesting and also important. So Dr. Hastings, may we invite you to the podium, please? Clicker is there.
Good morning, and thank you to the organizers for inviting me to share our team's work. It's a great honor to be at my first SWOG meeting. Here we go. So this morning I will be presenting our team's work on biomarker development for early phase clinical trials for melanoma prevention. Melanoma is the 6th most common cancer in men and women in the United States. Solar ultraviolet light is the major environmental risk factor for melanoma. The increasing incidence of melanoma, together with poor prognosis and high societal costs, supports the investigation of chemoprevention for melanoma. And melanoma chemoprevention trials are typically performed in individuals with atypical nevi, which is the clinical diagnosis, or dysplastic nevi, which is the pathological diagnosis. This is because these individuals have an increased risk of developing melanoma, and dysplastic nevi can be potential precursors of melanoma. Epidemiological studies support nonsteroidal anti-inflammatory drugs to reduce melanoma risk. Our group has prioritized Sulendak over other NSAIDs for a number of reasons. Sulendak has a favorable pharmacokinetic characteristics in the skin. Sulendak has favorable safety and tolerability for chronic use in clinical studies. Sulendak increases apoptotic markers in dysplastic nevi and induces apoptosis in melanoma cell lines. And Sulendak is more efficacious than aspirin and naproxen in decreasing prostaglandin E2 synthesis, keratinocyte proliferation, and tumor multiplicity in a mouse model of non-melanoma skin cancer. The team at the University of Arizona previously performed a randomized double-blind placebo-controlled trial of Sulendak in individuals at risk for melanoma. These individuals had both atypical nevi and benign nevi. At baseline, 2 of the atypical nevi were biopsied and plasma was collected, and then the individuals were randomized into 8 weeks of Sulendak treatment versus placebo. And at the end of the study, the 2 remaining atypical nevi were biopsied, as well as the benign nevi and plasma. From this, the primary endpoint demonstrated that Sulendak and metabolites of Sulendak were distributed in benign nevi with concentrations similar to the plasma. As a secondary endpoint, it was found that Sulendak treatment led to an increase in the apoptotic marker cleaved caspase 3 in the atypical nevi. And the ongoing studies in this project will be using the clinical specimens from this trial. There is a critical need for biomarker development for early phase melanoma prevention trials. The limited early phase trials in patients with dysplastic nevi have included clinical and histologic changes as early efficacy biomarkers, but failed to demonstrate changes in these endpoints. A few selected molecular biomarkers included in prior trials only had putative associations with the degree of dysplasia. Thus, there is a need to identify biomarkers of malignant transformation from nevi to melanoma. Clinical trials proposing melanoma transformation or melanoma development as the endpoint in high-risk subjects, such as those with a prior history of melanoma or an atypical nevite phenotype, would require enrollment of a very large number of patients and would be cost prohibitive. Thus, there is an opportunity to implement biomarkers of progression as surrogate endpoints in melanoma chemoprevention clinical trials. The goal of our study is to develop a gene signature biomarker of progression from nevi to melanoma. In the first phase that I'm presenting today, we did this using publicly available data sets. And in the ongoing phase that's coming up next, we'll use archive samples representing the spectrum of melanoma progression. So in this first study, we used 3 publicly available data sets that contained either dysplastic nevi or melanoma that arose in the context of a nevus. We termed this part of the nevus progressing nevus since it was known to progress to melanoma. So here we have 3 data sets. And the first row is the data set from the Kruger laboratory that included 5 benign nevi, 7 dysplastic nevi, and 16 melanoma specimens, where the RNA expression was analyzed by one-channel microarray. In the next row is the data set from Scatolini et al. That was included 18 benign nevi, 11 dysplastic nevi, 8 radial growth phase melanoma, and 15 vertical growth phase melanoma. And the RNA expression was determined in this data set with 2-channel microarray. And in the bottom row is the data set from the Bastion laboratory, which includes 17 progressing nevi and 20 melanoma lesions. And again, these are paired lesions, and the RNA expression was determined by RNA sequencing. So to first show that a small number of genes could distinguish nevi and melanoma, we looked at the ability of the top 10 differentially expressed genes in each of the data sets to distinguish the lesion types. So on the left in the Kruger data set, if you're looking in the top row, you see very nice separation of the 3 lesion types, the melanoma in red from the benign nevi in blue, the dysplastic nevi in green. And then if you look at the hierarchical clustering on top of that, you can see that there's greater separation. I should be playing here. There's greater separation between the benign nevi and the dysplastic nevi and the melanoma. And similarly, underneath is the PCA plots showing separation of the lesion types. In the middle column is the data from the Scatolini set. And here we see separation of the melanoma in red from the other 3 data sets, but you see that there's overlap, especially if you're looking in the PCA plot in D between the benign nevi, dysplastic nevi, and radial growth phase melanoma, but that those 3 groups are distinguished from the vertical growth phase melanoma. And then finally on the far right is the Bastion data. And here we see separation of the melanoma coded in red and the progressing nevi coded in green in both the hierarchical clustering on top and the PCA plots on the bottom. So next, we went on to use elastic net regularized regression models to generate mathematical models to distinguish the lesion types. In this type of model, you're selecting the genes that can differentiate the lesion types, and there's a penalty for including additional genes, so it reduces the number of genes selected. And you can see in the Kruger data set with the multinomial regression that we have separation of the 3 lesion types: the melanoma in red, the dysplastic nevi in green, and the benign nevi in blue. In the Scatolini data set, we have nice separation of the melanoma in red and the dysplastic nevi in green, but there's quite a bit of overlap between the dysplastic nevi, the benign nevi, and the radial growth phase melanoma. So in our next phase, we focused this model just to look at either the dysplastic nevi or the progressing nevi versus the melanoma. And here we have nice separation in the 3 data sets. So in the Kruger data set, there's separation of the dysplastic nevi from the melanoma. In the Scatolini data set, nice separation of the dysplastic nevi versus the vertical growth phase melanoma. And then in the Bastian data set, nice separation of the progressing nevi versus the melanoma. So the linear model was able to separate nevi and melanoma, but we did not identify any overlap in the genes selected by these different models. So we took an alternative approach and looked for overlap in the differentially expressed genes in each of the data sets. And you can see in pairwise comparisons of the data sets, we have overlapping differentially expressed genes that have either consistent up or down regulation. And then if you look for consistent genes among the 3 data sets, we identified these 6 genes that were upregulated in melanoma: C1QB, CXCL9 and 10, DFNA5, FCGR1B, and PRAME, and then 1 gene that was downregulated in melanoma. So these 7 genes represent our best candidates for a gene signature for melanoma progression at this time. To evaluate how these genes changed during progression, we looked at the gene expression within the Scatolini dataset because that dataset had the largest number of lesions in melanoma progression. And you can see that the gene expression of each of these genes changes linearly from benign nevi to dysplastic nevi to radial growth phase melanoma to vertical growth phase melanoma, supporting changes in these gene expression with melanoma progression. And CXCL9 had the greatest degree of gene expression with melanoma progression. Lastly, we used overrepresentation analysis from Reactome to identify biological pathways that the genes that we identified in these 3 analyses were overrepresented. So we took genes that were top 10 differentially expressed, genes that were identified in the regularized regression models, as well as genes that overlapped in at least 2 of the data sets, and did this analysis. And you can see that the bulk of the pathways here are related to the immune system. You have the S100A genes in metal sequestration by antimicrobial peptides. And then we have a lot of genes involved in communication in the immune system: cytokine signaling, interleukin signaling, the IL-4, IL-13, IL-10, and the chemokines, which includes the CXCL9 and CXCL10. So in conclusion, we found that a small number of genes can distinguish nevi from melanoma. We found that there were shared genes and immune-related pathways that were associated with progression from nevi to melanoma across the 3 independent data sets, and identified 7 genes that were shared in these data sets. We identified gene candidates that have known expression and function that are consistent with the role in melanoma progression, as well as identifying new candidates. And this first phase of our study demonstrates the feasibility of developing a gene signature biomarker of progression from nevi to melanoma, and also represents a novel approach to aid melanoma chemoprevention trials by using a gene signature as a surrogate endpoint. I lastly wanted to show you our future plans. So what I've presented to you now within AIM-1, our goal is to develop a gene signature biomarker to distinguish stages of melanoma progression. We have completed the top step here, demonstrating feasibility and identifying candidates in the 3 publicly available data sets. Our next step is to use archive samples so that we dramatically increase the number of samples so we have a better ability to identify and internally validate a gene signature using benign nevi, dysplastic nevi, and melanoma. And then in AIM-2, we will determine the effects of short-term Sulendak intervention on the gene expression profile using dysplastic nevi at baseline and after intervention. And then we will correlate the RNA expression using TempoSeq between these 2 methods. I'd like to end by thanking the team that did this work. This is funded by the NCI Division of Cancer Prevention. The PIs of the UA Cancer Prevention Clinical Trials Network are Drs. Sherry Chow and Julie Bowman. This work that I presented is funded by the Rapid Response Restricted Funds Proposal and includes Dr. Clara Curiel as the clinical co-investigator. Elizabeth Borden in my lab completed the analyses that I presented. Angela Adams did the literature review of the genes that we identified. Bonnie LaFleur provided the statistical support and the mathematical modeling support. And then lastly, the bioinformatics support from Drs. Melissa Wilson and Ken Buto at Arizona State University. Thank you very much.
Thank you, Dr. Hastings. This was a great presentation. We don't have any current questions in our chat, but anybody from the floor?
Well, I have to comment. I was at Arizona in the 80s, and I'm delighted to see that some preliminary thoughts thought at that time have continued to such elegant work. And I have 2 questions. One, have you been able to identify a profile that is not nevi dependent in skin melanoma that seems to just come out of nowhere? And then secondly, have you looked at these profiles in the very difficult areas of aqua melanoma or uveal melanoma? I have a particular interest in uveal melanoma because of a family history of it.
Would you mind repeating the question when you answer for the online?
Yes. Sorry, so first was if we had looked for a signature of melanoma that arises independently of nevi. And since the clinical trials are designed with dysplastic nevi as a risk for melanoma, we have not looked at that yet, but that would be another approach that we could take and consider. The second part of the question was whether we had looked at a signature for ocular or, acral melanoma. Right, uveal melanoma, so other types of melanoma. And at this time, our work has entirely focused on cutaneous melanoma. And I think that it would also be helpful in other studies. There, we wouldn't have precursor lesions and biopsies, but it's something that we can think about for the future. Thank you very much.
For our attendees online, Dr. Maskin said it's been neglected for a long time and it's very timely and fantastic work. Dr. Neuhauser has a question.
Yes, Dr. Hastings, thank you for that great presentation. It's very exciting work. I have 2 questions. And the first question is, when you're using the archive samples, what's the sample requirement? Can you use formalin fixed embedded tissues that need to be fresh frozen? Just thinking about, broad applicability, say to, SWOG and other NCTN groups.
So in these cases, we're looking for RNA expression. And in the study that we're doing, we're using TempoSeq as a way to do the RNA expression. That does not give you the sequencing, but has the advantage of being less expensive. So we will be piloting the TempoSeq, and that might be a less expensive way to do these type of studies in the future. And TempoSeq has been validated to be performed in the formalin fixed paraffin embedded specimens.
That's great news. That's great. And then if you could go back a few slides, the slides where you were showing the differential, these slides next. Okay, these were these data generated using the RNA-seq data, because you had 2 microarrays and 1 RNA.
This is microarray data from Scatolini, which is the oldest of the data sets, but it had a larger number of lesions and a larger number of lesion types for us to do this type of analysis. So it was a nice way to affirm the change in gene expression, not just between nevi and melanoma, but to see a linear change in that gene expression across these 4 lesion types.
Thank you.
Yeah, Cheryl? I was checking online.
Hi, as a patient advocate, I just have to say my dad had melanoma, so I really do appreciate the work you're doing to try to identify how best to serve patients. So again, thank you.
And I might have one last question. Doc, do you want to go first?
I was just wondering, because I had about how much like nicotinamide or niacin had been studied for the prevention of melanoma, because I've seen some conflicting data and I just didn't know if that was an opportunity to look at that in the setting.
I apologize. I'm not going to be the best person to answer that question for you, since my expertise is in immunology and this gene expression work.
Okay.
Karen, I can comment to it, if I may.
Yes, please.
Yes, so when the phase 3 trials on nicotinamide was done in Australia, they had a very small group of melanomas in their cohort, was primarily, basal cells and squamous cell. They have, I think it's about 3 or 4 melanomas in the entire sample size, and they were equally distributed among both groups, so they didn't really see they didn't have the power for it. I do know that there are groups that are interested right now in pushing forward the idea of using nicotinamide for melanoma. There is conflicting data where it's actually a chemopreventive agent for melanoma from the basic science perspective. So there is definitely more work that needs to be done on the basic science on melanoma to push it into clinical trials. I don't know if Sans is on the call. She might comment to it, but our motivation to push Sulendak is because we have strong data as far as the biodistribution of the drug and the actual fact that if we do get it to the skin and can modulate melanocytes.
Yeah, I was just thinking, if you're thinking of a study, to think of the different things that are being tested out there.
Yeah, absolutely. I mean, and you can think that this is really a tool, right? It's not necessarily dedicated to a specific drug. We are doing it with Sulendak because it's our expertise, but you have sulforaphane out there. You have definitely nicotinamide. So I think this is really the idea of this is to close a gap in a better assessment of biomarkers as surrogate endpoints for these prevention trials.
Thank you, Dr. Carroll.
One last question I have, and maybe there is no, answer, but when you look at the gene expression profiles, is a pathway or potential targets sticking out that might, make us think about some repurposable drugs? That's very in prevention. Anything that could be repurposed for some practical prevention trials?
Yeah, I think that is an excellent idea. So we can take a look at this data with that in mind. You can see that most of the pathways identified are in the immune system. And I think one of the challenging things for me looking at these plots is that each of these genes could have effects, either immune activating or immune suppression, depending on which cell type is expressing the gene, which cell type is expressing the receptor. So we haven't gone from this to a concrete treatment recommendation at this time.
Wonderful.
Thank you.
Thank you. Looks like no other questions. Thank you very much, Dr. Hastings. Thank you.
So our next presentation is from our patient advocate, Cheryl Jernigan. So we'll invite her to come up to the podium at this time.
Good morning. I can't begin to tell you how pleased I am to be here and great it is to see so many of you in person for a change. This has been a wonderful meeting to be at. Today, I will be sharing a quick overview of what's happening with SWOG's Diversity and Equity and Inclusion Initiative, or DEI for short. It's a comprehensive initiative identifying the DEI pillars, setting up SWOG's. Oh gosh, how did I
Just we have to click through it. Yeah.
Oh, this is me. This is the slide I'm supposed to be on. Setting up a SWOG's organization to support DEI and training stakeholders in DEI via the Team Science Module 6. I will also highlight the DEI planning resources available to you and the role of patient advocates in this process. Thanks to the Hope Foundation, SWOG was able to contract with Pope Consulting to do a detailed assessment of where we were in DEI and SWOG. They provided a number of recommendations, and now the board has begun to develop and implement strategies to drive DEI buy-in, organizational structures to support and sustain it, and systematic organization-wide systems fostering DEI and practices to ensure its sustainability. SWOG's DEI organization now includes you. You're listed at the bottom, but starting with the vice chair of DEI and professional integrity, and the search is currently on way for that person. We already have on board our DEI implementation fellow, and those of you who are involved in the breast committee or the cancer survivorship committee may already know her, Patricia Robinson. She's already hard at work. And then we also have the DEI monitoring committee that's being established. It's in the process of being established. It's not yet there, but it'll be similar to our data and safety monitoring committee. And they're looking for a chair to serve on that for that committee. So if you're interested, you might put your name in. SWOG's recruitment and retention committee, as well as patient advocates, will serve as key representative or key resources for you in representativeness and diversity in your clinical trials. And again, all SWOG members, all of you will play a valuable role in assuring that DEI is meaningfully embedded into our thinking, our culture, and our research. The goal is to increase our diversity and representativeness by 20%. As SWOG members dedicated to assuring excellence in your research, you will be strongly encouraged to take the Team Science Module 6. The module is currently being rolled out. Patient advocates and the retention committee have completed it. We had 100% participation from our patient advocates, and the SWOG leadership rollout is just wrapping up. And I'll go say our two chair people were the ones who they completed the course in a timely fashion. So I was glad. I was going, yes. But anyway, the next wave will be for the DEI pilot study chairs and the study teams. The course is going to cover the rationale for diversity. Why is it so critical in our studies, scientifically, morally, ethically, to achieve equity and to comply with FDA guidelines? It will also delve into the best and emerging practices across the clinical trial life cycle, including defining, reviewing, designing, and implementing and sharing information about the trial and the insights gained. The 5 steps that are needed and outlined, you should have received this. I need more hands. You should receive this in your packet, so look for it if you haven't already seen it. But it outlines for each of the steps.
Over there and get the sweaters, it's up to you, I don't care.
Hi.
If you're joining by Zoom, please mute your microphone.
comics don't
Oh.
care if you are offended. And
If,
you know,
For each of the steps, it outlines what we need to be doing in DEI. The define stage, we need to do, for instance, we need to develop
You want anything from
the
the
preliminary
garage?
forecast of the subpopulations and define the subpopulation barriers, and finally brainstorm solutions. During these last two steps, both the retention committee and our community advocates will be invaluable resources in helping us do that. The DEI planning resources that are available to you as a study chair or on the study team will include your patient research advocate and our community advocates, and the SWOG's Recruitment and Retention Committee, as well as the 5 DEI champions. They are already on board and working with the 5 committees that are implementing the DEI studies. And those studies will be in breast, myeloma, GU, lung, and GI. So you may have already heard about this from some of the committees that you other committees that you attend. Finally, as I already mentioned, the Team 6 module and the field guide will be invaluable resources. And the hard copy of the field guide is included in your packet. SWOG advocates are now committed to asking the question in everything that we do: how can we improve diversity and representativeness of our clinical trials? And actually, it's a question we all need to be asking. Quick refresher, because I know SWOG advocates, we have two types: the research advocates, which are your clinical trial experts who are embedded into all the committees, and we help in clinical trial design, protocols, and informed consent and other patient-facing and touching documents. In wrapping, by the way, our community advocates are community experts, and they work across SWOG committees as needed. So if you need someone from a specific community, please let me know. They provide a frontline community patient. They know what the patients in their communities need and want, and they advise on connecting with the communities they represent. So we already have 6 community advocates on board, and we're in the process of recruiting for the next 4. And as advocates, we are all asking some DEI, fundamental DEI questions, and we will probably be thinking of more. But for instance, what are the study populations and demographics, and what is it reflected in the accrual goals, and how should recruitment targets be established? Hello? I'm pressing forward, but it's not going forward. There, thank you. In wrapping up, why is diversity so critical to our clinical trials? Only with a diverse group of people can we be confident the results will apply to everyone who will one day use those drugs. How well a drug works, its chance of causing side effects, how the type of side effects may differ, and even the effectiveness differ by ethnic group. Bottom line, no diversity, no generalizability. And if your study is not generalizable, then it's at best incomplete and possibly a disservice or even harmful to some subpopulations. These are some hot links to additional information that dive more deeply into some of the things I've mentioned this morning. But if you want some firsthand experience from other committees that are doing it, I would suggest that you attend, or in some cases, look at the session online after this meeting of the 2 at the bottom, plus the one that I just attended yesterday, which was excellent, the SWOG Latin American Initiative. So in conclusion, I want to thank you for being here, and we'll be open to any questions you might have.
Thank you so much, Cheryl. And we'll take questions now, both from the chat as well as in person. Okay, Dr. Hastings is making her way to the microphone.
What a wonderful presentation and a goal to increase the diversity and representativeness in the clinical trials. I just had a practical question. Say, for example, in breast cancer and melanoma, where it affects, both genders and all ethnicities. But what do you do when, it's more common in women than men, or more common in fair skin versus dark skin individuals? What is the goal of the accrual?
Well, and that will vary by study, of course, but overall what we're trying to do, and I may not be answering your question exactly as you're asking, but overall in the design of accruing, we want to make sure that our SWOG trials are representative and have diversity. Now, not every trial will that necessarily be a key factor on, because it's more broadly distributed. But I will tell you, I serve on the NCI-CIRB, and we got a trial from one of the NCI networks, and it was specifically designed within the information. They said this affects Black men more than anybody else. But then when I took a look at the accrual, there weren't hardly any Black men that they were anticipating to accrue to this study. This is the kind of thing that we can't do or continue to do. We need to look at what is the population that gets this or develops this, and then what are we going to do about it to make sure that they're part of the trial. And it's going to take work and thinking, and that's why SWOG is putting so many resources and thinking into how do we help researchers, because it's not an easy question, and it will vary by site and it will vary by study. Did I answer your question?
You did. I think it was maybe a little bit more of a practical question. I think the first goal that the study participants are representative of the group affected. I just don't know in clinical trial design, does that give you the power to make it generalizable in all groups if some of the groups are smaller in some cancers? But such a worthwhile goal, and thank you so much for your presentation.
It won't give you in some cases, if the groups are small, it won't give you the data you need to say this is exactly how, but it gives you clues as to what needs to be looked at. And if there's a clue that, hey, we got a problem here, we do need to look into it. But I appreciate the question. Thank you very much. And thank you all for all the work you're doing. I can't tell you how much I appreciate it as a breast cancer survivor, and also as a co-survivor with my husband who died of prostate cancer. It's so important. Thank you.
Thank you so much, Cheryl.
Okay, now it's my pleasure to introduce Dr. Jason Zell, who will be updating us on S0820, the PACES study. Dr. Zell is joining us remotely, and I think I will advance the slides with the clicker.
Yeah, hello. Thanks for having me today.
But you didn't. Sorry.
Can you hear me?
Yes, we can hear you, Jason.
Okay, great. My name is listed as Patricia O'Kane. I can't switch it, but I will say Patricia's always behind the scenes, even though I've kind of been the face of this trial. So maybe that's appropriate. Can you show the first slide? Okay. Great. Unfortunately, yeah, there we go. Okay, now I can see it. This is our thank you. This is our tertiary prevention trial of colon and rectal cancer patients, stage 0, 1, 2, or 3, using eflornithine, Sulendak, or their placebos. It's been going on for a long time. You're familiar with it. Just a reminder, the primary endpoint is a true cancer prevention endpoint. We're trying to demonstrate if these agents can reduce the risk of either second primary colon cancers, which are rare, or high-risk adenomas, which are pretty common. So the event rate that we would expect in the placebo arm is about 27% for one of these happening in the 3-year period. We will check basically post-op year 1 to post-op year 4. Now, if we could go to the next slide. We're proposing a 60% reduction, you can see, between the placebos and the treatment arm. The next one is the study schema, showing that this is now a 2-arm study of eflornithine and Sulendak combined versus their placebos. Again, approximately 1 year post-op to year 4 post-op, which is when we typically get the 2 standard colonoscopies. You'll see we now have 332 patients accrued out of a proposed 389. We have a modification in place right now to lower the sample size based on an increase projected effect size of 60% in the primary endpoint. So that would leave us with 57 patients remaining. So I would encourage everybody to get out there, give us your enthusiasm over the last 57 patients or so, and I believe we can complete this study. Next slide. I think this is it. Yes. So I'm happy to take any questions, and just want to wish everybody well up there in Seattle. And thanks for your ongoing support of the trial.
Thank you, Jason. The floor is open for questions. There's nothing in the chat for now. Any questions from the floor, comments? Looks like there are no questions, and or Dawn is coming. Okay, Dawn has a question.
I just want to congratulate Jason on getting to this point. This has been a true labor of love, and the amount of time, energy, and effort he's put into every aspect of this trial. The fact that he's only has 57 patients left to go, we should all really, applaud his efforts, because it's really been an incredible journey for him.
Thank you, Dawn and SWOG. If that translates into 57 accruals, I will be most grateful. So thank you very much, everybody.
All right, well, thank you very much.
Okay, now we're going to the next presentation, which is also a virtual presentation. And Dr. Lucia Nappi will be presenting. So Dr. Nappi, you can unmute your mic and just tell us when to go to the next slide.
Hi, can you hear me?
Yeah, we can hear you, but you might need to get a little bit closer to your microphone.
Too close to the microphone? Is it better?
That's better.
Okay, thank you very much for the invitation. I'm gonna give you some updates about our SWOG clinical trial. This study was designed to answer a very simple research question in a germ cell tumor, which is, can we use microRNA 371, which is a very small non-coding microRNA that's secreted in the peripheral blood, to predict or anticipate tumor relapse in patients with early stage germ cell tumor. Next one. Next slide. So this is the design of SWOG clinical trial. Patients with all germ cell tumors, both gonadal and extragonadal, stage 1, 2, and more advanced, were eligible to be enrolled, and were allocated to 3 risk categories: low, moderate, and high risk, based on the pre-established risk of having active germ cell malignancy. Next, please. The schedule for the blood collection for the evaluation of microRNA 371 was established according to the risk of relapse, and was every 6 months for patients with low risk and every 3 months for patients with moderate risk. And the next slide, please. Pre and post active treatment, that could be radiation or chemotherapy or primary surgery for patients with high risk. Next slide. The study has been activated in the United States in June 2020. Sorry, go to the previous one. And the first patient was consented on July 27, 2020 in Canada. The study was opened in December to the CCTC, the Canadian Clinical Trials Group. And as on April 4th, 2022, we have enrolled 475 of the 956 patients, with a pace of 5 to 7 new patients per week. The table summarizes the patients with low risk, moderate, and high risk that have been enrolled so far. We have also amended the protocol, and the high risk cohort has been closed. So we are currently only enrolling patients with low risk and moderate risk, and among patients with high risk, only patients with clinical stage 1S. Next one. some of the the analytics part of these studies has been covered, will be covered by this R01 Transformer 37 award that we recently received from NIH. So this will essentially give us protection for the cost of the analytics part of the project. And I think this is my last slide. Thank you.
Thank you, Dr. Nappy. And we'll take questions now. And I'll start out first with a comment. For those of you who are not familiar with the R37 mechanism, this is really a great honor for Dr. Nappy because she's a first-time investigator to the NIH, and she scored so well on the application that the R01 was converted to an R37, which gives her an extra year of funding as a young investigator to develop this research program. So these are very hard to get, these R37s, so we extend our congratulations to her for that award.
Thank you very much.
And my question for you is, you have just had tremendous accrual in this study, 5 to 7 patients a week, and just excellent accrual. And I'm wondering, what do you attribute this rapid accrual to so that your other studies might learn from this success?
Yeah, that's a very interesting question. So I'm very, very grateful for all the to all the investigators to have invested in this study. I think there are like several aspects of this study that have favored this very good accrual. The first one, I think it's just a very easy study to do. So it doesn't require a lot of clinical information, just basic clinical data and additional blood work. So it's not an interventional study. We're not basing any clinical decision on the test. So I think the fact that it's very easy has definitely contributed to the rapid accrual. And the second aspect, I think, is that all the germ cell tumor and testicular cancer community, which is a very small, relatively speaking, community, is extremely excited about this clinical trial and about the potential clinical impact of this trial. And because germ cell tumor is a curable disease, we haven't had a lot of outbreaking news in terms of treatment, but we could have a very important, significant change in the clinical practice because of this biomarker. So I think that's the other aspect that have contributed to this rapid accrual.
Great, thank you. Any other questions for Dr. Nappy? Okay.
Yeah, I have a quick question, Dr. Nappy. Without knowing the exact details and feasibility, have you ever considered maybe opening it up? I saw you are opening up in Canada, maybe with the Latin America initiative. Would that be something that could be considered?
Oh yeah, that's. I think that's a very good point, and I'm definitely open to the option. Yeah, absolutely. And I know that all of those Latin American components. So yeah, absolutely.
We will connect you with that group then in that case.
Yes, please, thanks.
And I think we have a few of them here in the audience today, so we'll make that connection. Okay, thank you, Dr. Nappy.
All right, now it's my pleasure to introduce Dr. Kathy Crew, who is here in person, who will talk about her cluster randomized controlled trial of patient and provider decision support to increase chemo prevention. It's S1904. There you go.
Thanks. Sorry.
Just
Okay. So the S1904, as many of you know, is specifically addressing the problem with underutilization of breast cancer chemoprevention with anti-estrogen therapy among high-risk women. So our goal with this trial is to enhance informed shared decision-making with these web-based decision support tools, which we call Real Risk and BNAV for patients and providers respectively. So since this is a multi-level intervention, we're using a cluster randomized control trial. So there are 26 centers throughout the US who are being randomized 1-to-1 to the active intervention arm, which are the decision support tools plus standard educational materials, versus control sites that are getting standard educational materials alone. But our control arm will eventually get access to the web-based tools once the trial is complete. So we're targeting high-risk women who have a history of atypical hyperplasia or lobular carcinoma in situ. So these are high-risk benign breast lesions, and this is a patient population that's particularly high risk for breast cancer, but also are the ones that are more likely to benefit from anti-estrogen therapy. And then because it's a provider and patient intervention, we're also enrolling healthcare providers that see this high-risk population. And our primary endpoint is chemoprevention informed choice, which is a patient-reported outcome at their 6-month follow-up. But we're also assessing a number of other patient-reported outcomes, as well as actual chemoprevention uptake, adherence, reasons for discontinuation. And we really want to understand how these tools can best be implemented into clinical practice. So there's also this implementation aim where we're doing qualitative interviews of both patients and providers to get their insights on what's helpful and what's not so helpful. So this trial was officially activated in September of 2020. And first, some of the successes of this trial. So as of December of last year, we were able to enroll and randomize all 26 recruitment centers. And we're about 3/4 of the way done with enrolling the healthcare providers, at least at 24 of the 26 sites. And we're about 3/4 of the way done with completing the baseline interviews of these healthcare providers, just to get sort of their baseline needs assessment. And at least 18 of the sites have already enrolled. We're about 1/3 of the way through with patient enrollment. So this is the breakdown in terms of the 149 providers that are enrolled in each of the intervention and control sites. And the main thing I wanted to highlight is that there is a diversity in terms of practice of specialty within the providers that we're enrolling. So the majority are medical oncologists or breast surgeons, but we also have a fair number of primary care providers. And in addition to MDs, we also have about 1/4 of the provider participants are allied advanced health professionals, including nurse practitioners, physicians assistants, as well as RNs. Oops. And then in terms of the patient enrollment, as I mentioned, we're about 1/3 of the way through with patient enrollment, and at least based upon our projections, if we can once all of these 26 sites are activated, if we can reach our accrual goal of 15 to 16 patients per month, we should be able to complete patient enrollment within the next 1.5 years. And the thing that I'd like to highlight too, so whenever we have any technology-based intervention, we also want to make sure that we're not increasing health disparities through this digital divide and access to this technology. So we did make a point of trying to, as we were talking about DEI, increase diversity in our study population of patients. So I failed to mention that our Real Risk decision aid is available in both English and Spanish, and we actually rigorously test it in our predominantly Hispanic population in New York City before rolling it out to this SWOG trial. So nearly half of the participants are racial ethnic minorities, particularly more than 1/4 are Hispanic women. So some of the challenges that we faced with this trial. So from a design perspective, when we're doing randomization at the site level as opposed to the patient level, ideally, if we're going to optimize power within the trial, we should have equal accrual of patients at each of the sites. So for 415 patients across 26 sites, we want about an average of 16 patients per site. And so some of the sites, the slide is a little off, but some of the sites are, haven't, I think 8 of the sites haven't enrolled any patients thus far. And, you know, we don't want to close down accrual at certain sites. We want it to be, we want to finish the trial and make it practical. So we are capping enrollment per site at 32, but we are having monthly calls with all of the sites just to get a sense of what's going on at the, you know, the boots level, at the grassroots level, and seeing, you know, what some of the barriers are to accrual and things that we can do to enhance accrual at sort of those lower accruing sites. And then the other challenge that I'd like to highlight is just that, you know, you think that with a web-based intervention, it should be fairly easy. This is a minimal risk study. There's no drug that they have to take, no toxicities that they would have to endure. But with such a low touch intervention, we also encounter, you know, just lack of actual completion of the study intervention. So about, you know, in our intervention arm, about 3/4 of the women have at least logged on and partially completed the real risk tool, and only about half of them have fully completed it. So these are the things that we're thinking about. I think in particular in a high-risk population without a cancer diagnosis, who's otherwise healthy, it's important to think about different ways to keep the participants engaged. So again, we've been working with the sites in terms of reminders, recruitment brochures, things like that to make the site coordinators help in terms of engaging the sites. We've also tried to name a patient advocate at each of the sites and also have them participate in the calls so that we can really get the patient perspective in terms of what would be most helpful for them. So I think that's the last slide. So this is our contact information. So if you have any questions about the trial or eligibility or study procedures, those are the contact information that you'd use. Thank you.
Thank you. Thank you, Kathy. No questions on the chat so far. If not from the podium, I have a quick question, kind of a practical question. And, you know, accrual is really going well. That's really, we want to congratulate you. I noticed, so 13% PCP and 13% others. So 2 related questions. How were you able to find the PCPs? Are those PCPs attached next to the cancer center's oncologist's office and they know, or are they independent? That's one. And the other question is the 13% other, are those gynecology? I think understanding it will help so much more with our subsequent trials.
Right. So I think that every site has different models. A lot of them are NCORE sites out in the community. Some are academic centers. Some have dedicated high-risk clinics that see these patients. And then others, you know, may get followed by a nurse practitioner or seen by, so most of those that were defined as primary care physicians were either internists or gynecologists. So I think that, you know, as a cancer research network, we're used to, you know, dealing with cancer patients and medical oncologists who see them in the cancer clinics. But I think, you know, for the prevention trials, we really do have to think broadly in terms of the different practices, including the surgical practices who see these high-risk populations, genetic clinics, et cetera.
And how to reach them, right?
Exactly. Yeah. So I think it just varied based upon the different models of the clinics and what patients had access to in those various clinics.
Looks like no further questions. Thank you very much. Thank you.
Our next presenter is a virtual presentation from Dr. Deirdre Hill. So Deirdre, you can unmute your mic. in advance.
Good morning.
There we go.
I'm delighted to present an update from the National Myelodysplastic Syndromes Natural History Study this morning. Next slide. The MDS study was established as a resource that would include biospecimens from individuals with myelodysplastic syndromes, MDS, or idiopathic cytopenias of undetermined significance. And this resource would also collect clinical data that would be linked to the biospecimens. The goal of this resource was to support future studies that will have high impact for MDS patients. As this study is moving closer to completion of the planned enrollment of 1,750 individuals, questions have been raised about the availability of the resources to investigators. So I would like to present this morning the external data release plans. Next slide. So the MDS study investigators are developing an interactive online inventory browser to provide details about the MDS data that will be available, including clinical data, diagnostic classifications, which they have worked on very much in depth, the genetic variants that have been identified so far, and digital slide images. Information will be forthcoming regarding access to the specimens. This interactive online tool will include some information that will allow investigators to assess the feasibility of their potential research plan and submit an application form for review and approval by the MDS study team. And the launch date of this website is tentatively scheduled for June 2022. Next slide. So some details about this inventory browser. It will allow investigators to identify a research cohort of interest for a study and to conduct some initial feasibility analyses on the data, including sample sizes. For statistical power calculations, it will allow filters to be applied so that study subsets can be identified. And the prototype under development is illustrated here. So in conclusion, I think the MDS study resource will be a very valuable source for prevention studies, and encourage those who are interested to follow up at the MDS website. Next slide. So in conclusion, I'd really like to gratefully acknowledge both NHLBI and NCI for funding this resource, and thank all of the investigators and sites that have contributed, and most particularly thank the study participants. Thank you.
Thank you, Dr. Hill. Now we'll take questions, and I'll start with a question. I'm wondering what the team has been thinking about and what types of prevention studies could be done with the specimens and data that have been archived. What are some of the big research questions that are being considered?
So I cannot tell you all of those that are being considered, but I can say that the genetics in particular are being interrogated for understanding those that are related to progression to malignancy, and that identification of those biomarkers would then be utilized to understand and potentially treat and potentially prevent high-risk individuals.
Thank you. Any other questions?
I have a question, Deidre. Thank you so much. This is Banu. Actually, two questions. You mentioned data. Does this also include samples, or is it just data?
Currently, it only includes data and the digital images, but it is planned to include access to the samples in the future.
Okay. Or, for example, would they do sequencing and release sequencing data, for example? Or do the investigators need to receive the samples and then sequence themselves?
I don't think there are plans to sequence at this point, but I think that it would be worth following up with that question.
Right. And then my other question is just to understand how it works. Is it planned to release the data to a group of investigators, or actually, groups like us, for example, SWOG Prevention Committee, if we come up with a research question, is that okay as well?
It absolutely is. And in fact, I think what they're really hoping is that individual investigators will go to the website and fill out that feasibility form and start the process for obtaining access to the data.
Wonderful. Thank you.
Thank you so much for that presentation.
All right. Well, next, I think it's me.
Is she still on? I just, yeah, I
Deidre,
just
are
had
you there?
a quick question about what the anticipated sample size is and where we are in that collection.
So there are about 1,675 out of 1,750 recruited at this point. That would be the longitudinal cohort that's being followed up for clinical outcomes. In addition, there's about, there's over 500 individuals who are enrolled only in a cross-sectional study. So those would be the two populations available.
Thank you. Okay, I will give a very quick two study update without slides. One is an update on CTSU EA 1151. As you know, that's the ECOG-ACRIN study comparing tomosynthesis mammographic imaging screening to regular mammograms, the TMIST trial. The update is that out of planned 165,000 patients, they accrued close to 66,000. They are at 65,900 as of end of March 2022. The other update is on actually a study that I will be running, S1418, as you know, the addendum to look at mammographic density changes in patients receiving adjuvant pembrolizumab versus placebo, triple negative breast cancer. The latest is that we are now next in submitting our amendment. The breast committee will submit it to the CIRB, and hopefully, if approved, we can start the analysis. It's been a long time, but I think they have completed all of their own amendments, so they can move on to ours right now. Any questions related? Yes, Leslie.
So if I'm not mistaken, we've approved the reduction in sample size for the TMIST trial. So that 65,000 women already randomized represents over half of our accrual target. I think the accrual target now is 126,000.
Oh, okay, thank you so much for the update. Must be very recent. Dr. Pisano's slide had not reflected that. Thank you so much. Thank you. Let's see if there's something in the chat. All right, thank you so much.
Our next presentation is also a virtual presentation from Dr. Julia McGinnis, and she is actually going to give two back-to-back presentations. So we'll turn it over to her now. Dr. McGinnis?
Hi, everyone. Hi from New York. So the first presentation is updates on our assessments using an artificial intelligence-based mammographic evaluation to assess response to endocrine therapy and other chemopreventive therapies. So this is updates on our analyses for SO812 and S1007. Next slide, please. So as we've presented at previous meetings, here at Columbia, we've developed a convolutional neural network-based breast cancer risk evaluation. It's a deep learning technology that's applied to mammography and evaluates unique mammographic features beyond mammographic density. The output of this is a breast cancer risk score from 0 to 1 that gives a continuous measure of estimated breast cancer risk. We've demonstrated with training and testing sets that this model is an accurate, independent predictor of breast cancer risk and was actually more accurate than mammographic density, which is a known breast cancer risk factor and predictor. Drawing from the data with mammographic density, that change in mammographic density with tamoxifen can predict future breast cancer in high-risk patients, we also have applied the CNN model to mammograms from women with atypia, LCIS, and DCIS who did and did not receive anti-estrogen chemo prevention. And not only did we observe change in the model with therapy, there was a greater decrease in predicted CNN risk with chemo prevention, which is sort of illustrated in these heat maps on the right from one patient with DCIS who received chemo prevention, showing the decrease in sort of hot areas in the CNN model. Next slide. So in addition to showing that we can observe change in the CNN model with endocrine therapy given as chemo prevention, we've also evaluated whether or not change in the CNN model in a breast cancer population can predict relapse among women who receive adjuvant endocrine therapy for hormone receptor positive breast cancer. And so this is results from a retrospective analysis among women with hormone receptor positive stage 1 to 3 breast cancer. And we applied the CNN model to serial mammograms obtained after they completed definitive local therapies and were receiving adjuvant endocrine therapy. And similar to what we've seen with change in mammographic density with tamoxifen, both in the adjuvant and chemo prevention settings, we also observed that there was a significant change in the CNN model at 1 year, and that this was differential based upon which patients ultimately in this retrospective cohort had breast cancer relapse. What's shown here is that those who had relapse really had no observed change in the CNN model at 1 year, and those who did not have relapse did have an observed change, and this difference was significant. One thing to note about this analysis is that it included women who received both tamoxifen and aromatase inhibitors. Mammographic density in this setting is limited by the absence of true observed changes in women who are postmenopausal, specifically who receive aromatase inhibitors. Next slide. Oh, can you go back one? Yeah, thanks. So basically what we're presenting here is analyses that using prospectively obtained mammographic data sets from 2 SWOG trials, one in the chemo prevention, SOH12, which was vitamin D for chemo prevention, and the other using the responder trial, S1007, in the early stage breast cancer cohorts. The goal here is to further evaluate whether, one, we can observe change in the CNN model with these different breast cancer prevention or treatments, and also just get a better sense of whether, specifically in the responder trial, whether these changes truly correlate with breast cancer relapse events. Next slide. Next slide. Oh, thanks. So I'll start with SOH12, which is the vitamin D for chemo prevention. So just to give background on this trial, it was a randomized controlled trial among women with atypia, or sorry, rather at high risk for breast cancer, which included women who had atypia, but also other breast cancer risk factors. Women, these were high risk premenopausal women who were vitamin D deficient at baseline and then were randomized to either vitamin D supplementation for a year or placebo for 1 year. And as part of the trial, yearly mammograms were collected with the primary endpoint being change in mammographic density measured using the Cumulus technique, which is volumetric. They also, as part of this, though, collected mammograms out to 24 months, as well as various blood specimens for additional biomarkers that are associated with change in mammographic density, including IGF-1 and other markers. So our goal with the analysis using the CNN model was, one, to observe changes over time using serial mammograms in the CNN model in a high-risk population, and also see if we could see differential changes in CNN risk with vitamin D supplementation versus placebo. The idea being that perhaps we can observe changes in the CNN score that we wouldn't just by measuring mammographic density. It's important to note with this trial that actually the primary endpoint of change in volumetric density at 1 year was not met. There was no significant difference in change in mammographic density at 1 year between the vitamin D and placebo arms. Next slide. So we actually do have the analysis for the CNN changes from this trial. And here's just the baseline characteristics which have been previously published, which we just confirmed here for the trial. This was a younger population of women in their mid-40s, predominantly non-Hispanic white, but still with a minority of patients who were Hispanic or non-Hispanic Black. Overweight by BMI for the most part, and here are some of their other breast cancer risk factors as well as their baseline serum vitamin D level. Obviously, based on the trial design, these are well balanced. Next slide. So here's really the main results. So we were looking specifically at change in CNN score over time on those serial mammograms that were obtained as part of the trial, and then seeing if how they sort of compared to change in the mammographic density as I've previously described. And actually what we found is that similar to mammographic density, where really no significant difference in that change was observed between the groups, there was also no significant difference in change in CNN score between the vitamin D and placebo cohorts. We also did paired t-tests, and there was really no significant change from baseline to 1 year and baseline to 2 years in the CNN score. So actually pretty consistent with the primary findings of the study with change in mammographic density. Next slide. Also, the slide seems to have gotten messed up a little bit, but we also just did simple analyses to see, well, what factors might correlate with change in CNN risk score, particularly at 1 year. And really the only thing that was significant was an inverse correlation between change in CNN risk and age. Everything else, including change in mammographic density, did not show a significant correlation. And this was similar when we tried more multivariable analyses. Next slide. So just to briefly go over the next steps, which is our analysis of mammograms from the responder trial. This has not yet been done. It's in process. So our plan is to apply the CNN model to serial mammograms to evaluate its ability to predict breast cancer relapse in this population. And just to remind everyone of what responder was, it enrolled women with hormone receptor positive, HER2 negative breast cancer that was pathologic stage N1, so 1 to 3 positive lymph nodes. They evaluated essentially whether Oncotype DX recurrence score could predict chemotherapy benefit. And this is practice-changing study showing that in postmenopausal women, Oncotype DX can be used to stratify who actually benefits from chemotherapy in this population. And so, of course, with this trial, we have long-term follow-up for breast cancer events and relapses. And so our goal with this is to further validate our findings from our retrospective cohort in this cohort with prospectively obtained mammograms. And so we're going to conduct a case control study case cohort study rather, among 845 women in this study. We're also going to evaluate as part of this, which I haven't mentioned, a special MRI evaluation that we've developed as well that can predict Oncotype DX recurrence score to validate it, given that all these women have Oncotype scores. So this is planned to go forward soon. It'll be included in the next amendment for the responder study. And so we hope to start collecting breast imaging for this study in the next year. And also just important to note, this was funded by a SWOG Hope Foundation Impact Award awarded about a year ago. So next slide. So just to summarize, similar to our findings from the primary analysis of SOH12 that didn't show any change in mammographic density with vitamin D, we also did not observe change in the CNN model with vitamin D supplementation, which also, is consistent with the primary conclusion of the trial that really we don't have enough data to support the use of vitamin D as chemoprevention. As I mentioned, we'll next validate our findings in the adjuvant setting using prospectively obtained imaging from S1007. And then ultimately, beyond this, we hope to incorporate evaluation of the CNN model into the design of prospective clinical trials so we can prospectively perform the model. I think I have one more slide. These are just the acknowledgements and funding. This is our team from Columbia. And of course, again, acknowledging the Hope Foundation Impact Award that's funding this. That's all I have.
Thank you, Dr. McGinnis. We'll take questions on this, and I'll start with a question. When you were showing your background slides, you had a graph of women who had relapsed and women who had not relapsed, and their CNN scores over time, I think up to about 5 years. And it looked like between years 4 and 5, there was almost a sudden drop in the CNN score, although the magnitude on the y-axis, I'm not sure how to interpret those CNN scores. But what do you attribute that drop in the CNN score among women who relapsed, between years 4 and 5? Any ideas about that?
Yeah, I think some of it is that our numbers in terms of women who had mammograms to those years, including those who relapsed, dropped. The median, I think, follow-up for our retrospective cohort was about 4 years, 4.5 years. And so when we looked at that, I think it's mainly a product of low numbers at that point. Because up until that point, consistently, the CNN score was higher in those who relapsed at each year.
Thank you. And so that we can understand a little bit better about the units, how do you interpret like each unit change in the CNN score?
Yeah, I think that's a great question going forward as well. Right now, we don't have, unfortunately, it doesn't provide us an absolute risk. It just gives us sort of a relative risk on the scale. And what happens with these CNN models is the more data they're exposed to, that scale actually changes. Initially, when we applied this model to a high-risk population, we actually saw higher absolute CNN scores than what we observed in the adjuvant population, which you think would be counterintuitive. So the long story short is we don't yet have an absolute way to sort of take those risk scores and say this patient has X risk of relapse. It's just still relative compared to the other, like the rest of the cohort, essentially.
Okay, thank you. That's helpful. Any questions either on the chat or here in the room? Okay, we'll have you go on to your next presentation now.
Perfect. So next slide. Okay. So this is a presentation of a proposal in process. It's more in the early stages. So this is a proposed study of alternate dosing of exemestane among high-risk women with atypical hyperplasia and lobular ductal carcinoma in situ. Next slide, please. Back one. So just as a background that I'm sure everyone is aware of, obviously there's been a lot of interest in the past years to decades on optimizing chemoprevention dosing for women at high risk for breast cancer, with the goal of maximizing the benefit of that chemoprevention while minimizing toxicity and improving adherence. And obviously a pivotal trial in this space was the trial of low-dose tamoxifen for 3 years compared to placebo, showing an approximately 50% risk reduction in breast cancer incidence with tamoxifen compared to placebo, and a low rate specifically of serious adverse events, including thrombosis. But there still hasn't been an equivalent trial with aromatase inhibitors in postmenopausal women. So next slide. So one trial that has completed and we're awaiting the final results, hopefully in the next several months to year, is a study of alternate dosing of exemestane in the pre-surgical setting. This study evaluated doses of exemestane at the standard dose, which is 25 milligrams a day versus 25 milligrams 3 times a week versus weekly for 4 to 6 weeks before surgery amongst postmenopausal women with stage 0 to 2 hormone receptor positive breast cancer. In this trial, the primary outcome is change in serum estradiol, which is associated with breast cancer risk, and also in the adjuvant setting with aromatase inhibitor-based therapies, change in serum estradiol can be associated with early breast cancer events like relapses. And so these two trials, but particularly this one in terms of the alternate dosing of exemestane, serves as the foundation for the study that is in process through SWOG. Next slide. So this is the proposal sort of building upon those two previous studies. So we're proposing a randomized trial among postmenopausal women at high risk for breast cancer, including those with atypia, LCIS, or hormone receptor positive DCIS, who have not had prior breast cancer diagnoses before this, have not received prior anti-estrogen chemo prevention, have not had bilateral mastectomy, and for those who have DCIS have undergone definitive breast surgery and or radiation for local therapies. And what we're proposing is a 2-arm randomized study of the standard 1-to-1 of the standard dose of exemestane, which is daily, versus an alternate dose of exemestane that will be informed by the final results of the pre-surgical trial. So either 3 times a week or weekly, pending the results, the presentation of those results. Patients would receive either dosage of exemestane for a total of 3 years, so drawing from that the low dose tamoxifen study. And while we'll also be evaluating for breast cancer events and incidents to make this a more manageable trial in terms of sample size, our primary endpoint, again, drawing from the pre-surgical exemestane study, is % change in serum estradiol at 1 year. As I mentioned before, change in serum estradiol in the adjuvant setting and also in the high-risk setting can correlate with breast cancer risk, including risk of relapse. And so in addition to all of this, we're proposing additional assessments, including obviously safety, toxicity, and toxicity-related PROs, for example, in particular for this patient population, evaluating differences in vasomotor symptoms or arthralgias. We'll also be evaluating adherence, markers of bone health, given the use of aromatase inhibitors here. And then, as I previously mentioned, sort of drawing from our hope to evaluate the CNN risk model prospectively, we'll also be building that into this study to get a better sense of the dynamic changes over time, and also if those also correlate with change in serum estradiol. So this is still in the early phases. I think I might have one more slide. Next. So the next steps with this are before, we really need to determine the dose, the alternate dose of exemestane for the study, be it 3 times a week versus once a week. And so we do await the results of the pre-surgical study to inform this, since this really is sort of the next step from the pre-surgical study. In terms of the actual development of this concept, last year this was selected for me to attend for the project for me to attend the SWOG Young Investigators Training course, which was postponed from last September to in person this September. Actually, since I made these slides, the date is at the end. So I hope by then we'll have the alternate dosing of exemestane, but that will also help flesh out a lot of the details of this proposal. And then ultimately, we're not yet at the stage where we've submitted that 10-page concept to the NCI for review. This is still in the early phases past the triage. So that's all I have. I welcome any input or suggestions.
Thank you, Dr. McGinnis. It's great to hear the progress on this concept. So we'll open it up for questions now from the audience as well as those who are participating virtually?
Andrew, I don't know if you were on the phone for I-SCORE, but you, this is Leslie Ford from the NCI. If the pre-surgical trial is the one that is run by Andrea DeCenzi, you should be seeing, if you haven't already seen results.
Yeah, they just haven't been published yet, or presented. So I don't want to sort of jump ahead and give you.
They were presented at our internal investigator meeting last week. So.
Oh, okay.
It's moving along.
Yeah.
Yeah, that's. I have a question or clarification. So no biopsies are built in, right?
No, not at this point in the concept. No, I think that's an interesting question, going forward, especially for, say studies that evaluate, like imaging based biomarkers. It's a question of what we're seeing, but at this point I have not incorporated biopsies into it.
Right. I think it makes it from the practical accrual point of view, much easier for sites and other sites.
And this is Marian. I'll ask a question. Given that we had this nice presentation on DEI earlier and thinking about how results would be generalizable to all who have, certain cancers, if they're more common in some groups than others, can you tell us about, who might be eligible for the trial you're hoping to do, and if there are particular groups that you'll want to target who might have a greater risk of these lesions?
Mm-hmm. It's actually pretty broad in terms of how we envision the eligibility criteria right now, just postmenopausal women who are high risk by these lesions. I certainly welcome any advice from those who have experience in this area in actually attracting and enrolling a diverse group of women to this study. Obviously, I'm coming from Colombia, where our patient population tends to have a higher proportion of Hispanics and non-Hispanic Blacks, but I know that's not the case at every center. And so the hope is that we can sort of balance perhaps centers that are more diverse with those that have less diversity through this. It would be multi-center. So I do welcome, as we get closer to actually having this, be an actual study, potentially through SWOG. I think that's really an important question.
Thank you, Dr. McGinnis. Any other questions? Okay, thank you so much.
Thanks.
All right, now moving on to our last speaker, but not least, Dr. Eileen O'Connelly, phase 2 study of intraoperative radiotherapy for DCIS after breast conserving surgery. You have your clicker here.
Yeah. All right, there you go.
Okay, hi, thank you for having me. So I'm here to give an update since the fall meeting on a trial I've discussed over the past several years, which is looking at the use of intraoperative radiation for low risk breast cancer. So at the fall meeting, we had shown a proposed randomized trial at that time. So previously this had been presented to DCP as a single arm study looking at local in-breast recurrence. And the feedback was that they wanted to see a randomized design. So we proposed initially a randomized design enrolling low-risk women who are postmenopausal, screen detected unifocal DCIS, which is hormone receptor positive, and grade 1-2. And then they would be randomized to either surgery alone or surgery with IORT. And initially the plan was to do an intention to treat analysis. However, we then presented this, I presented in the November, December to the NCI Bold Committee, and they actually felt that it would be better for the analysis, and also with talking with Kathy, that we keep the group after surgery. A second analysis would happen on the post-pathology to better risk stratify patients, because about 10% of patients enrolled on final pathology based on size, grade, or surgical margins may actually be unsuitable or cautionary risk. So rather than keeping them in an intention to treat analysis, the feeling was to keep them separate and keep the low risk group as its own cohort so that you can compare them directly. Those that go into the cautionary unsuitable risk would be would have the option for additional surgery or radiation at the treating physician's discretion. And we would include them for analysis on patient and physician reported outcomes regarding cosmetic outcome and aesthetics. And primarily looking at the toxicity of combining IORT with whole breast radiation. But for the primary group, if you maintained a low risk category on the post-pathology, then we would have them followed for the primary outcome, which is in-breast recurrence at 10 years. And this is either DCIS or invasive disease. And this is powered to show a difference of expected based on prior trials, the RTOG and ECOG trials, of about 12% at 10 years is the expected recurrence rate with surgery alone. And IORT is powered to be, with 80% power, 4% is considered promising for local in-breast recurrence. Patients will not be required to take hormonal therapy. It is recommended. We're planning to look at rates of actually taking it. And an additional modification that's come up based on discussions is now that we would include a stratification so that we would balance the group based on patient age, as well as intent to take hormonal therapy. So this is the revised design that has now been reviewed by our patient advocate, and I've been working with Kathy, who is our statistician, who's been really helpful to finalize the concept, and I hope that we'll be back to DCP soon. But so this is where we are now with the concept.
Thank you. I mean, this is a lot of work. I mean, it's like you developed 2 protocols, over a couple of years. So yes. Dr. Crew?
So do you think that since we're hearing 2 DCIS proposals back to back, that patients could potentially be eligible for both, or would you consider, because I think moving forward with our prevention trials, it might be good to think about, collecting their standard of care serial mammograms for additional imaging analyses or sub-studies in the future.
Yeah, so I did include as an additional endpoint, it's exploratory, but the collection of mammograms prospectively for these patients. Whether they'd potentially be eligible for Dr. McGinnis's trial is separate because we're not requiring hormonal therapy is recommended, but it's going to be a discretion, patient discretion. And then the other secondary analysis is we did incorporate a proposal to look at Decision RT, which is a biomarker that's been developed looking at immunohistochemistry staining of a series of genes that are thought to be predictive for risk of recurrence in surgery alone and estimate the benefit of radiation. So that is being incorporated, and we have the support of Prelude, which is the company that's actually developed that. And the idea is to look at both the initial surgical, the initial biopsy, as well as the final surgical resection, and actually compare the score and then look at how that's predictive of the outcome as well.
Any other questions? Nothing in the chat. All right, looks like none. Thank you so much. Thank you for your hard work. We are right on time and have a few minutes for an open forum, discussions, ideas, comments, suggestions. Please feel free to either come to the microphones or send us messages via chat. Dr. Mayskin? And then Kathy?
I have one sort of general suggestion based on the request I asked Dr. Hastings for. How about acromelanoma? Acromelanoma is a non-UV associated cancer found in the skin largely of Black people. And I think it's going to be extremely important to look at that group for DEI reasons. And I'm sure that there are funding in that area for that. And the comment I'm making now is I think that we can look at lots of different situations for DEI relationships that we haven't thought about in the preventive world. And so I just would urge this committee, which I think is working impressively well, I must say, and to pursue that general thought.
Thank you. Absolutely agree. Dr. Hastings, do you have any comments to that? Agree. All right. Kathy, I think you were gonna.
I was just gonna make a comment about trying to, it's a nice idea to try to combine trials, but it's SWOG standard that until you've reached your endpoint of one trial, you can't go on to the next. So I don't think it's gonna be possible to combine the two DCI questions.
I see. Thank you. Thank you for that information comment.
Yeah, I was imagining so that the eligibility criteria may differ, you know, for those two trials, because Eileen's trial is all DCIS, but Julia's trial includes DCIS, but other, you know, atypias. Yeah.
So this is Sancy. I wanted to just add on to Frank's comment. I think that is absolutely true, that it sort of is an unprecedented opportunity to really think about how to use acral lentiginous melanoma and mucosal melanoma as well as an inroad, as a model into how you really address DEI issues, because of the difference in the pattern of melanoma development between you know, more darkly pigmented and lightly pigmented skin. So it's actually a really nice to think about it as a model of how we can start to incorporate DEI thinking into our standard practices. I think is a true opportunity. So thanks, Frank, for saying that. I think that it's really right.
Thank you, Deidre, for your comment. Sancy, sorry. Any other comments? Questions? Well, looks like we will be able to end a little bit early, so you guys can go to the plenary session reception. This was a great meeting. We've had great attendance, actually. It appears more than actually when we do it all in person. So thank you very much for presenting and your contributions. Thank you.